Hey, good morning, everyone. Just go ahead and let me know in the chat if you can hear me okay. Perfect. All right, I'm gonna give everyone a couple minutes to log in because I said 9 o'clock, and we'll go from there. We'll start up our third PowerPoint here. I'm probably gonna go the full hour just because those tests usually put us behind a bit, so we'll go straight until 10, I think. How was the test? It was a bit of a shorty, but hopefully get you some ideas of kind of questions that might come up on the final. It was fair. That's the best thing I can hope for with exams, that they'll say they're fair. Tough but fair. Keep in mind, these are little simpler questions than what you're going to see on the actual like Pharm exams from like Pharm 1 and Pharm 2. Those are going to be more like clinically based and picking the right medication for the right disease state, the right patient, things like that. So, but we'll get you ready for all of that with the rest of this class here. Yes, good morning to you all. If you have any questions about anything, typically, I'll mention this again when I start recording, I have to validate the test before I can answer any specific questions about it to make sure there's no like miskeys or high misses or anything like that. So I don't know if I can address the test specifically just yet, but I will put out an announcement about that if there's any high misses or anything. But if you have any questions about stuff we're covering or concepts or anything, go ahead and preload them up in the chat, or if you want to go to that sticky board and put them there. I haven't seen too much use there yet, but it's there for you. That's a good question, David. So do I answer the sticky board all the time, like during the week? No, typically that's just for class time. I'm not going to be going in and checking that. Usually if you need to like get to me throughout the week, either messaging through Canvas or emailing me is the best way to get a hold of me. It's really just designed to let me answer questions for you guys as they pop up for during the class time period itself. Yeah. I emailed you my questions because I was unsure if you wanted them on the sticky board. The benefit of the sticky board, if I can answer them during class, is that everyone gets the benefit of hearing from the answer. So the more that you can post stuff up where everyone can see it, or I can address it during class time, the better, because I think everyone could benefit. Oh yeah, regarding the quiz, like I mentioned, let me go ahead and validate that, and then I'll get back to you in terms of any issues that, yeah. So for specifically test questions or something, you just email me, that's fine. But it's almost 9 o'clock. I'm gonna go ahead and start recording. And so we're gonna get started here with our third unit. Again, if you have any questions, feel free to post those up in the chat or on the sticky board. As mentioned a second ago, I'll validate the test, so I got to go through and find out if there's high misses, if there's a miss key or something like that, and then typically I'll address any high misses in an announcement, usually today or tomorrow sometime whenever I get the stats from Leanne, but we'll go from there. So gonna hit the ground running. This is a big section, and we have 2 weeks to get through all the material for the next test, so let's get to it. So anyways, we're hitting unit 3, which is our pharmacokinetics. This is going to get into actually the crunchy bits in terms of the details of like how our body is handling these drugs, like what happens to a drug after it enters the system. So getting into it, we're talking about A, D, M, and E. That is standing for absorption, distribution, metabolism, and elimination. So how does the body interact, or how does the body handle the drug from the time it gets in to the time it leaves the body. And we'll talk about some other things like loading doses and steady states and all of that. So basically, we recall that pharmacokinetics is, again, what the body's doing to the drug. The pharmacodynamics is what the drug is doing to the body, right? We're more worried about the kinetics today. We'll get much more into the pharmacodynamics a little bit later on, but that's kind of what we were talking about with like our ED50s and toxic dose 50s and all that kind of thing there. So from the time a drug actually gets into the system, the drug dose comes in, whether it's a tablet, whether you're injecting it IV, whatever the case may be, there's some absorption phase that occurs here. When it says liberation, that's typically when the drug is, like, if it's in a tablet form, it's dissolving in the stomach acid or something like that, or getting into solution. From here, we're going to see that the central compartment is basically like our bloodstream, right? When I say central circulation, that's essentially what I'm talking about. At this point here, we have free drug, and there's many things that can happen to it. We'll see that a portion of it's going to actually go out to the tissues where the drug is actually going to work. So if it's a drug that works on the heart, it will distribute from the blood and go to the receptors that are there on the heart itself, right? Not all the drug just goes right to where it's supposed to work. You'll see it's going to go throughout the body in a lot of cases. So we'll find that there's cases where you have tissue reservoirs where a drug can accumulate over time potentially, right? And then that's the distribution phase we'll talk about. In terms of metabolism, this is where we're going to talk about biotransformation, and predominantly the liver is going to be the big place where this occurs. And then we'll talk about the excretion, where you can see like the biliary tract is responsible for this in a lot of cases, or the kidneys are going to be another important one as well. So let's get into the first one here, being absorption. So when we talk about absorption, one of the big things that we're going to see is that drugs have to be able to cross these biological membranes, right? So we recall our cell membrane has this phospholipid bilayer, and you're going to find that permeation is going to be a challenge for certain substances depending on a lot of the physiochemical properties of that substance. So when we say permeation, we just mean it's moving through some sort of barrier. So whether it's crossing from the GI tract through the intestine wall, going across the capillary wall, the blood-brain barrier, any of that is considered to be permeation. When we see this, we're going to see that there's two things we're going to talk about. There's going to be aqueous diffusion and then lipid diffusion. Lipid diffusion is specifically when it's going to be passing across that lipid bilayer. And so we're going to see that things like lipophilicity is going to be really important in terms of that happening there. Frequently when we're talking about this is mainly going to be passive processes here for the most part. We'll talk about some active ones as well, which are also very important. But in general, when we're talking about passive diffusion, things tend to go from areas of high concentration to low concentration. And so everyone should be pretty well familiar with that concept there. Things like to find a homeostasis, so everything wants to get to the same concentration. So if you find you put a lot of solute or a lot of drug in one side of a partition, it's going to then permeate across if it's able to do that across that membrane. We're going to see, though, that lipid diffusion is going to be really important because in order to get across those membranes, they have to be at least somewhat lipid soluble, or they have to have some kind of help, like a protein transporter or something else. And so looking at this, you can see some examples of passive diffusion. So here would be an example of an aqueous channel or pore that the drug can just passively go through here, right? From area of high concentration, there's 4 drug molecules here, down into where the lower concentration is. In the case where we have strict lipid diffusion, here's an example of a more lipid-soluble molecule being able to pass straight across here. In this case, when we have active transport, this is a carrier-mediated example. There's a transporter that actually uses ATP to cause that to cross over. And again, this is a process where things can go from areas of low concentration to high concentration. So that's kind of the opposite. And that's why it requires energy to kind of go against that natural flow of things that would normally passively diffuse the opposite direction there. And again, if you don't have any energy, then those carriers just don't work at that point, right? So when we're talking about aqueous diffusion, this is occurring with really large aqueous components or compartments of the body. So we're talking about, between the bloodstream and say like the urinary tract and all kinds of different ones we're going to see there. And again, the blood vessels are going to be one of the main places where we're seeing things cross over from the central circulation out into the tissue or the peripheral tissues there. And this is all governed, this permeation that occurs, by what we call Fick's law. And so we're not going to get real heavy into the math here, so don't let the formula sort of intimidate you. But what I want you to understand is what the different variables mean here in terms of the actual flux that occurs, or the actual amount of drug that is going to be permeating across one of these membranes or from compartment to compartment. So flux, as I mentioned, is that process of it crossing over, and I'll show you a picture of what this looks like to make it more obvious. And this can actually apply to lipid diffusion as well, as we're going to see. So both aqueous and lipid diffusion are going to be governed by this, and I'll show you some examples of that in a moment. Basically, though, what we're going to find is that the first component here, the first variable, is the difference in concentration. So how much concentration you have on the outside minus how much concentration you have on the inside. The bigger this lower concentration is, the closer this is to zero, which means you're closer to getting no flux occurring. So if these were equal, there'd be no flux because everything is already at the same concentration, so there's no way it's going to go, right? So that's not going to happen. So by putting a lot of drug on the outside of the membrane, you can cause some of that flux to occur. So the bigger this difference is, either a bigger amount on the outside or a smaller amount on the inside, more flux happens, right? Pretty straightforward. In terms of the other variables here, we're going to see that the area that we're applying the drug to is going to be really important. So the larger the surface area we're applying the drug, the more flux happens. We'll talk about the permeability coefficient in terms of how lipid soluble a drug is. That typically is one of the most important characteristics we'll see there. And then this is divided by the thickness of the membrane. So the thicker a membrane is, the bigger denominator, the smaller this number is going to be here. So this is inversely proportional. Thicker membrane means it's more difficult for that drug to cross over. Okay. So what that means is that for larger concentration gradients, faster or more extensive diffusion and then absorption, right? You're going to see that things with large surface areas are going to have better absorption. That is why if you look at the small intestine, if you look at cross sections of that, you see all those little villi, those microvilli that increase the surface area quite a lot when you're looking at the GI tract, which is why it's such a good place to absorb drugs. Or consider things like the skin, so when looking at drug absorption, if you apply a drug over a large area of skin, you get more absorption than if it was just a small area. But also think about things like the thickness of the membrane. The skin's a good example of that because a lot of your mucous membranes quite thin and they're able to get drugs across pretty easily. But imagine if you were trying to apply drug to two areas of the skin. So imagine you're trying to do it, say, to like your stomach versus the soles of your feet. Which one's going to have the thicker skin? Well, probably the soles of your feet, and that's going to have a lot worse drug absorption than it would, say, on your stomach, for instance. So, and again, this is the body's way to try to achieve what we call steady state. And we'll talk about what steady state means in just a little bit when we talk about metabolism. So here's a good picture, I think, kind of illustrating Fick's law and what the different variables are going to have an effect on here. So looking at this flux that occurs in the direction the arrow is pointing, the larger the concentration difference is between outside to inside, the more flux that happens. The larger the surface area, the more flux happens, and then the thinner the membrane, more flux happens. Okay, so keep those relationships in mind, and that is helpful when you're looking at examples of like, okay, where am I applying this drug? Where is it being absorbed from? How good is it being absorbed? All that's going to play a role here. And additionally, how lipid soluble this drug tends to be is going to be related to how easy it's going to cross these membranes, right? And this is all a passive process. No energy is being used here whatsoever. So as I mentioned, those lipid barriers tend to be pretty significant barrier to absorption, and we can actually find that pH is going to be playing a big role in terms of how easily drugs can cross over. And so we're going to probably trigger a few people's PTSD of like, chemistry and biochem classes from the past, because we're going to talk about the Henderson-Hasselbalch Equation and how that's going to have an effect on the ionization state of a drug. Okay, and again, this usually intimidates a lot of people. It's not that difficult to think about. But basically, when I say that pH affects the ionization state of the drug, it means whether the drug is charged or uncharged. Okay, it has a positive charge on it or not. Typically, when things are charged, they tend to be more polar. The more polar something is, the more water soluble it is. Okay, because it has that positive charge, it's easier to be more soluble in water. That also means it's less lipid soluble. Okay, things that are uncharged are less polar, so they're going to be more water insoluble but more lipid soluble. So in general, what we're going to see is that uncharged drugs cross lipid membranes much more easily, and I'll show you some clinical examples of how this actually pops up here. So we're also going to look at not only the pH of the solution where the drug is, but also the pKa of the drug itself. That's going to be the other important point there in terms of determining the ionization state. And again, the Henderson-Hasselbalch equation is what we're going to be using here. And so some of the notation I'm going to be using here is going to be the pKa. This is basically the acid dissociation constant of the drug itself. And basically, if you were to put a drug with a pKa in a solution has the same pH, so if it was like a pKa of 5 and I put it into an acidic solution with a pH of 5, you basically would find that the drug is going to be 50% charged and 50% uncharged, okay? Also, another way to say it would be protonated or unprotonated, okay? And so whether we're talking about weak acids or weak bases, this is also going to make a difference here in just a moment. So I'll make that more clear in a second here. In terms of the notation, if you have A just basically means a weak acid. If you have an H on it, that means it's protonated. So I'm adding on a hydrogen molecule. That means it's uncharged, okay? Because normally when a acid is in the unprotonated state, it is charged, and there's a little minus on it. That means it's in the unprotonated, but it's a charged state. So this means it's more water soluble in this case here, right? For a weak base, you're going to find that when it's protonated, when you add on this H here, it's actually charged at this point, okay? So it's protonated, going to have a little bit harder time crossing those lipid membranes. When it is by itself, notice here there's no minus on it, which means it's going to be unprotonated, it's uncharged. Okay, so more lipid soluble there. So what does this mean for our purposes? So imagine you're giving a drug orally, it has been liberated, it's in solution in the GI tract, and imagine we have a lipid membrane that is trying to cross to get into our bloodstream, right, to eventually go to the liver and all of that. So if you have a weak acid here, and let's say we have two different states. We have the ionized or unprotonated state here for the weak acid, or we have the protonated form of it, which is going to be unionized, right? It's going to be uncharged. If it's in the state where it's protonated, where it has this extra hydrogen, it's not charged, it's going to be more lipid soluble, so it's going to cross more easily, right? Well, when is this more likely to occur? Well, if I put a whole bunch of extra hydrogen ions into the solution, that's going to make it more likely for this to occur here, right? Because I put more hydrogen on this side, it's going to force this reaction to go in this direction, so I have more HA here, right? So when do we have more hydrogen ions in solution? Well, when you have an acidic solution. That's what makes it acidic, is all those extra hydrogen ions floating around, right? So what this means is when a weak acid is in a acidic solution, it can cross these biologic membranes much more easily, okay? We're going to see the exact opposite for the weak bases, right? So weak bases here, when it's by itself and it's unprotonated, it's uncharged. So it crosses quite easily into this different compartment. When it is charged, when it's in a protonated state, so if it was in an acidic solution, it's going to just bounce right off that membrane because that charge keeps it very unlikely for it to be able to cross that lipid membrane there, okay? So basically when a basic drug, a weakly basic drug is in a more basic solution, it's going to have an easier time crossing over, okay? So weak acids in an acidic solution cross easily, and then weak bases in a basic solution cross more easily. So what I like to say is like dissolves like. So if you put a weak base into a basic solution, it's going to be unprotonated, it's going to have an easy time crossing because it's uncharged. If you're going to put a weak acid into an acidic solution, here it does become protonated, but that's okay because that now makes it uncharged. It's going to have an easier time crossing over, okay? So weak acids in an acidic solution, easy time. And then weak bases in a basic solution are going to have an easy time crossing over too, right? And now you're probably thinking like, well, why do I care about this stuff? That matters quite a bit because you can actually change how well drugs can get absorbed, especially in the GI tract, by affecting how acidic or basic the solution that the drug's actually in. And if you imagine in the GI tract too, that that pH level changes quite drastically depending on where you're at. The pH of the stomach is 2. Pretty acidic, right? Versus when you get into the small intestine and your pancreas is dumping out all this bicarb, now all of a sudden you got a much more basic solution, neutral to basic. So you're going to find that depending on where the drug is in terms of the GI tract can affect how well it's going to be absorbed. So, and a way we would actually look at this in the Henderson-Hasselbalch equation, what this is really telling us is that based on the pH of the solution the drug is in, based on the pKa of the drug, right, it'll tell us basically what this ratio is between the non-protonated to the protonated species here. So for acids, right, with a pH, if it was like say in a low pH and have a low pKa, you're going to find that a lot more of it's going to be favoring this HA here, this uncharged but protonated state, versus if I'm in a weakly, dealing with a weak base and I put it into a basic solution, I'm going to be favoring production of this unprotonated but uncharged weak base, right? Because again, as it gets more basic, you have less hydrogen ions floating around, so less of it's likely to form that BH plus here, okay? So I like this picture because I think it gives a good example. So imagine if you have the pH is equaling the pKa. So if I have a drug that has a pH of, say, 6.5, or pKa of 6.5, and I put it into a solution that is 6.5, you're going to see that it's 50-50 split between the protonated to the unprotonated state. So it's really not helping me or hurting me in terms of the absorption of the drug there. But if I were to, say, put it into a more acidic solution, say I were to put that drug into, say, the stomach, where the pH is like 2 and there's all these extra hydrogen ions floating around, you're going to definitely be more likely to predominantly be formed that HA there, which means that that drug that's a weak acid is going to be much more likely to be absorbed at that low pH. Okay, so weak acids get more extensive absorption at low pHs, versus a weak base would have a really hard time getting absorbed because it's in that really protonated state. A higher fraction of it is, right? On the flip side, though, if I were to, say, take that weak acid and put it into a more basic solution, say I'm getting up like 10 or 11, you're going to find that the charged state for that weak acid is more predominant. It's not likely to be absorbed there, versus the base is going to have a really easy time. Okay. So clinically, when does that actually come up? So let's talk about the drug aspirin. Most people have heard or have taken aspirin at some point in their life here. Aspirin, acetyl salicylic acid, is another name for it. So if you ever see aspirin abbreviated as ASA, that's what it stands for, acetyl salicylic acid. Well, it has acid in the name, so it stands to reason it's a weak acid, right? So what you find here is that with a weak acid like aspirin, when you put it into a low pH solution, say for instance the stomach, you're going to find that it's more uncharged. It's protonated, but it's uncharged because remember the A minus combined with the H, and now it's lipid soluble. So that means the aspirin has an easier time being absorbed from the stomach than it would the small intestine, because once you get into the small intestine, pH goes up to neutral to basic, and then you're going to find that it's more in that charged state, that unprotonated state, kind of harder time being absorbed, right? Or what if I change the pH of the stomach? We'll find there's medications that can actually do that to decrease acid production. That can have a negative effect and decrease the amount of aspirin you're absorbing potentially, right? That could be a problem. So you're trying to give aspirin to a patient who needs it for cardiac protection, but you're decreasing their absorption. Maybe they're not going to be protected as well anymore, right? On the flip side, let's look at an example of a weak base. We have morphine here. Morphine, we use as an opioid analgesic. We use it for pain relief, especially chronic pain patients. Obviously, to give that orally, with it being a weak base, it's not going to get absorbed from the stomach very well because the pH is really low, and it's going to be in that charged protonated state, so it's not going to be very lipid soluble. However, once you get to the small intestine, pH goes up. Now you're favoring that unprotonated state is going to be more lipid soluble. Okay, so kind of think through that process. Just remember, like dissolves like. Weak acids are more easily absorbed in in acidic solutions. Weak bases are better absorbed in basic solutions. If you get at least that far, you got 90% of it, right? And you'll see that it can range pretty greatly depending on the drugs we're talking about. Now, don't memorize these numbers here. That's not the purpose. It's just to give you an example of the different pKa's you might even run into. But with aspirin, it's like a pKa of 3.5. So again, putting it into a solution of a pH of 2, like the stomach, you're going to get that pretty well absorbed because so much of it's going to be in that protonated, uncharged sort of state there. So let's talk about our permeation. So we have special carriers that help us out, because all that stuff we've been talking about is all passive diffusion, right? So things happening along their concentration gradient from high to low concentration, and then no energy is being expended here. Let's talk about where we need special carriers to help us out in these cases. See, David's asking, can this transport have negative effects on the chemistry of the drug? In some cases, yeah. So, well, I guess not the transport necessarily, but what we can find is that the pH can definitely cause degradation of the drug itself. There's some drugs that we have to give in special coatings to prevent the stomach acid from actually destroying it. So if you ever heard of the drug like Nexium or Prilosec, if you ever look at one of those capsules, they have those little tiny beads in it. That's actually the drug being protected by a basic or an acidic safe sort of coating there. That way it doesn't actually dissolve until it gets into the small intestine where the pH is up. But We'll look at some other cases for drug interactions and things like that could be some issues. So getting into special carriers, again, these are going to be used for certain specialized sort of functions there, right? So for instance, with like the blood-brain barrier or in the renal tubules, we have a lot of special carriers that are moving things that may be unable to cross by simple permeation alone. Either the molecules are too large or their physiochemical properties are such they don't really allow for them to cross on their own. Note here, these are not governed by Fick's law, so it is capacity limited, meaning once I saturate all those proteins, once they're all filled up, all the transporters are filled up, nothing else can cross until they've then done their job and they reset and can then carry something across. So if you recall, with something with simple permeation, if I keep increasing the concentration gradient, so I keep increasing the concentration on the outside, I'm going to get more and more flux, right? The more drug, the more is going to cross over, right? That's not capacity limited. Here, we're going to find that this is. So we can actually saturate this process and actually slow it down. Note as well that this requires energy, so it requires ATP for this to occur most commonly, and then also can go against the concentration gradient, okay? So that's very different from passive permeation or passive diffusion, where you only saw things going along the concentration gradient. This may go against it. So here's an example of a multi-drug resistance type 1 transporter that is typically abbreviated as MDR1. This is also known as P-glycoprotein. So if you ever see PGP, and you can find these proteins all over the place, right? They may have different kind of flavors of protein, but they can be found in the brain, the GI tract, the testes, all over the place, right? This drug is meant to be an efflux pump. So say you were to absorb a molecule into a cell, this could then pump it back out. And you're like, well, why in the heck would you ever want to do that? Well, certain substances you don't want to get into the body, right? So say, for instance, this was in the blood-brain barrier. The blood-brain barrier is very particular about what it wants to get into the CNS because that's a very protected sort of site. So this is used to kick out things that it doesn't want there, certain substances that are poisonous or toxic or something like that. The GI tract can be another place where this happens quite commonly as well. And so if you've ever heard about drug interactions where they say, don't take grapefruit juice with this, you're like, well, why grapefruit juice? Like, who cares? Like, this stuff's gross anyway. Well, a lot of old patients typically like grapefruit juice. It's kind of one of the few things that still tickles their taste buds, as it turns out. So they really enjoy grapefruit juice. But there's chemicals in the grapefruit juice that actually shuts down this protein. And that's really important because if you shut down that protein, and certain drugs would normally be going through that and being effluxed out back into the GI tract, well, now all of a sudden, you're not having as much as that occurring, so the levels of the drug in the body actually go up pretty significantly, and that can lead to things like liver toxicity. That can lead to something called rhabdomyolysis, where you actually are breaking down muscle, and we'll look at a lot of that in the cardiovascular section coming up next semester. But this is just one example of how drug interactions can come about. This is a food-drug interaction where grapefruit juice, which seems pretty innocuous, can have pretty deleterious effects, and have actually killed some patients potentially. Here are some other examples of these different types of transporters. There's no need to really memorize all of them. Really, PGP is the biggest one I'll be talking about throughout this course and as we go forward, but they're everywhere, right? So here, imagine we have some hepatocytes. This is how we might actually eliminate some drugs through the bile ducts and actually out into the GI tract, right? Because the biliary tract empties out into the small intestine. This is one way we might actually do that, by using these drug transporters that are utilizing energy to pump things perhaps against the concentration gradient, or perhaps they would not have been able to diffuse across themselves, okay? So that's something you may see occasionally. Here's some of the GI tract. I mentioned PGP being an efflux pump, so it'd actually be shuttling things out in this direction, out back into the intestinal lumen. So some other forms of permeation that can occur, we have things like endocytosis. So most of you are familiar with this. If a substance is too large, or maybe lipid insoluble or otherwise impermeable, this is where basically the cell can engulf that molecule and take it into itself. Usually it'll pinch off and form a little vesicle, like a little membrane around it. This is good for things like B12 with intrinsic factor, or like iron absorption can only occur via this process. There's no other good transporters or passive way for iron to get into the system. And opposite of that, you have exocytosis, which is just the opposite, where you're actually taking that vesicle filled with a neurotransmitter or calcium or insulin, whatever the case may be, and then you have that fused with the cell membrane to expel it out into the bloodstream. So we see this quite often with like hormones. We see it a lot with different enzymes and things like that. And again, this picture, I'm sure most of you have seen something similar to it with your basic biology classes and things like that. But again, the plasma membrane is able to take things in, which you have endocytosis, and things can send things out through these vesicles, which would be exocytosis. Pretty straightforward there. So that's how drugs get absorbed. What happens after that actually occurs? Well, they have to be distributed throughout the body. And so one of the big concepts we're going to talk about is going to be the volume of distribution, or VD is how you're going to see that abbreviated there. And basically it's trying to tell us, and it's kind of a theoretical concept or mathematical concept, it's trying to tell us basically how farly distributed does a drug go, like once it's in the bloodstream, right, that central circulation, how far distributed out into the tissues does it get, right? Does it like to hang out in the fat tissue and the muscle and all of that, or does it like to hang out in the bloodstream? Okay. We're going to see some different things that are going to affect that in terms of the physiochemical properties of the drugs. And I'll show you some examples how we actually can calculate this and why it actually comes up in a lot of cases. But this is important, right? Because say, for instance, a drug wants to stay in the bloodstream. That's just its natural way of being. But it works out into the tissue. Well, that's not a very good drug if it's not actually ever going to get out to its site of action, right? So there's some things we can do to actually help to affect that. So basically how we calculate this, and again, I'm not going to have you do much math in terms of calculating out actual VDs on the test, but again, it's the concepts I want you to get, because as a PA, if you're out there working, no one, very infrequently would anyone ever say, hey, can you calculate the VD of this drug, right? That's what your pharmacy friends are for. But knowing the concepts and knowing what's kind of going on with the patient, and as their disease progresses and drugs change and things like that, you want to have an idea of what's actually going on behind the scenes. This is what I'm trying to show you. So the volume of distribution is frequently described in liters, right? So it's saying like how big of a volume am I having to fill with this drug here, essentially, right? So basically what I can do is I can look at the amount of drug in the body, right? So I'm giving a dose of a drug, so 500 milligrams, 100 milligrams, whatever the case may be, whatever the dose is. And I'm going to divide that by the concentration that I actually get in the plasma, okay? Plasma being a sign of how much drug is there in the central circulation in that bloodstream. And this is normally going to be milligrams per liter. So when you actually calculate this out, milligrams would cancel out and you're left with liters left over. So imagine if you have a drug that really likes to hang out in the bloodstream and doesn't really distribute out into the tissues. Well, you're going to have a very large amount of it, a very large concentration left there in the plasma, because it's all there to be measured in the blood, right? And so you'd probably have a bigger denominator, and such you'd have a lower overall VD, right? Well, if I have a drug that likes to really distribute far out into the tissues, it just loves being out in the tissues, says keep me away from that bloodstream, I want to go out into the tissues, the fat, the muscle, everything, then you'd find that there's not much left to measure in the bloodstream. So this number would be quite low, that concentration in the plasma. So lower denominator means that the VD would be much larger, right? So it's telling you how far distributed out that drug goes into the body. So an example here, so imagine I give 25 milligrams of a drug is administered, and then I get I'd say I do a blood draw right afterwards. The plasma concentration is 5 milligrams per liter. Basically just divide that out and say 25 milligrams divided by 5 milligrams per liter. Milligrams cancel out and I get 5 liters left, okay? And so that can tell me how far distributed out that drug goes. I can compare that between different drugs, and that can give me an idea of just how distributed, where the drugs are actually going at. And typically what you're going to find is that one of the biggest determiners of how farly distributed a drug is going to go is how lipophilic it is. Okay, the more lipophilic it is, the easier it has time crossing all of those lipid membranes, the easier time it's going to be able to distribute into the tissues. And I'll give you one really good example of when that comes up. So anyway, so high volume distribution drugs distribute out far, out into those tissues there. So let's imagine we have two different drugs here. So we have drug A is hydrophilic, and we have drug B is lipophilic. Okay, so drug A is hydrophilic, meaning it likes to be in that central circulation where all that water is, right? Drug B is lipophilic, so it likes to be in the tissue, right? Because it's able to cross those membranes quite easily, so it's able to distribute pretty far just with passive diffusion processes. Now let's imagine I have two twins, and they're identical in every way, and I give one of them drug A, and I give one of them drug B. So they're identical in weight and size and all of that. I give them both the same dosage amount of drug A and drug B, right? So for the first twin, of drug A, I get a concentration of 10 milligrams per liter. So if I were to divide that out, volume distribution being the dose divided by the concentration, I get 5 liters, okay? Okay, so well, how do I compare that to another drug? Well, let's imagine that lipophilic drug, the concentration that I get in the blood is only 0.5. Okay, well, I get the same dose, but I'm getting a much lower concentration, well, where did all that drug go? Well, it went out into the tissues. And so if you divide that out, you can see here 100 liters. So you're getting a much larger apparent volume that drug is distributing out to get that concentration, right? This is a theoretical number. Patients shouldn't have 100 liters of fluid on them. If they did, they'd probably be dead, right? But that's why it's a theoretical number, and it's useful for doing things like comparing and seeing where these drugs are actually going. So, and you can see here that typically by taking the weight of the patient out of the equation, we can go ahead and get what we call liters per kilogram volumes of distribution. And this is useful because it can actually compare it to different medications to one another. We can actually figure out, if you have a 100 kilogram patient or a 25 kilogram patient, you can actually directly find out what their specific volume of distribution is. But let's look at some examples here where this might be important, right? So for instance, things like heparin. Well, heparin, if anyone's heard of that, is an anticoagulant, right? So anticoagulants working on the blood. Where's all the blood at? Well, it's in that central circulation. So it's probably good that it has a low volume of distribution because it can get right to where it needs to work at, right? It makes pretty good sense. On the other hand, though, imagine we have something like, let's say, for instance, we have morphine, right? So we have morphine. Where does that need to go to work? Well, opioids, like morphine, they work in the spinal column. They work in the brain. So you probably want them to have a high volume of distribution so they can cross over and actually get to the site where it's working, which is the central central nervous system. So having a high volume of distribution for that's pretty good as well, right? Because it's getting to where it needs to work. So every drug will have a volume of distribution. In general, how you would classify a drug as having a low or a high volume of distribution is if it's greater than 1 liter per kilogram. So like methotrexate down would have high volume of distribution. Everything less than 1 is a low volume of distribution. So that's a pretty handy rule of thumb that I use for determining if something's low or high volume of distribution. So let's say, for instance, we wanted to, and like clinically, when would we ever use this, right? Well, let's say, for instance, we wanted to estimate if I gave a dose of a drug to a patient, could I estimate what their plasma concentration would be? Well, why would I ever need to do that? Well, if you wanted to make sure you got to the right therapeutic concentration, right, you want to make sure, imagine you have a narrow therapeutic index drug like we talked about last week. You want to make sure the levels are high enough to treat the disease that you're trying to treat, but they're not too high to where they actually cause toxicity, right? So I could try to give a drug and prospectively sort of estimate how much I need to give to achieve that specific concentration for that patient, right? So I could estimate what concentration I'm going to get based off a given dose of a drug. So imagine here I have a 70 kilogram man. I'm going to give him 100 milligrams of drug C, which has a volume distribution of 0.6 liters per kilogram. So is that high or low volume distribution? Well, it's less than 1 liter per kilogram, so I'd say it's low volume distribution, meaning it likes to hang out in the central circulation in the blood supply, right? Predominantly. It's not all there. It's not all sequestered there. There's some going out to the tissues, but in general, right? So what's his estimated plasma concentration? How can I figure that out? Well, remember this relationship here that VD equals dose, the dose I administer to the patient, over C0, that initial concentration that I get. Well, first I got to figure out what his volume of distribution is. So I can take that 70 kilograms, because I know his weight, and multiply it by that liters per kilogram of that drug, right? Well, kilograms cancel out, and so now I know this patient has a volume of distribution for that drug of 42 liters. Pretty straightforward. So 42 liters equals that dose that I'm giving, 100 milligrams, divided by C0. This is my X. This is what I want to know. And in general, for most of medicine, if you can do basic algebra, you can do everything, right? So I know, a lot of places require you to take, calculus and all kind of stuff. We don't use it all that often, to be fair, at least for my pharmaceutical calculations. But looking at this, I can now rearrange the equation. So I put C0 over here on the left-hand side. I take the 42 liters, put it underneath here in the denominator, and what do I get? I get 100 milligrams divided by 42 liters, and now it's 2.38 milligrams per liter. Okay, so what do I do with that number? Well, now I can compare it to see like what is the therapeutic, what are the reference ranges for that drug to be therapeutic. So if the drug had, say, a therapeutic range of 2 to 5 milligrams per liter, then I can say, well, that's a good dose of the drug because it's getting right there in that range I need it to be in order to treat that patient's disease state, right? Or let's say the therapeutic range was, say, 5 to 10 milligrams per liter. Well, I know this is not enough. I may have to give him a bigger dose in order to get to the right concentrations, right? So these are kind of actual examples of where this would come up. So what are some things that can affect volume of distribution? Because again, not every patient is going to handle these drugs the same. We can find different processes can actually lead to changes in volume of distribution, such that a patient may not behave like you would expect, like those kind of population averages that a lot of those values are working off of. So what are some things that can decrease the volume of distribution or make it more likely to hang out in that central circulation? Well, one thing is plasma protein binding. So if you have proteins that are binding up the drug and preventing it from permeating out to the tissues, that's going to sequester it in that central circulation and lead to a lower volume of distribution because it's all kind of being stuck there. And so you can think about things like, well, what kind of proteins do we have in the bloodstream? Like albumin's a really big one. Albumin binds to a lot of drugs and keeps their volume of distribution relatively low. Other things, if you have dehydration, so you're kind of trying to preserve all that water in the blood supply to keep your blood pressure up because you're dehydrated, then that can also concentrate that drug in the blood and lead to a lower volume of distribution. What are some things that can increase volume distribution? Excuse me. Well, things like renal failure or things like liver failure or states where you're holding on to a lot of fluid can definitely do this. So for instance, if I have renal failure and I can't process all that urine, I'm going to hold on to all that fluid. It's going to start to accumulate in the, in the abdominal cavity. It can accumulate out into the, the peripherals. That can lead to spots where all that drug can then distribute to, right? So that's now leading to a larger volume of distribution because all that extra fluid is there for the drug to permeate into, okay? So volume distribution can change depending on the disease state for the patient. And that's an important thing to consider, especially as patients change from day to day, week to week, or month to month, right? One other, a good kind of real world example I wanted to make mention of with volume distribution is also thinking about things like urine drug screens and illicit substances, right? So if anyone is aware, for instance, the main psychoactive compound in in marijuana is THC, right? It's tetrahydrocannabinol. And so that actually is a really lipophilic substance, which makes sense because, if you imagine some of the dosage forms for marijuana, you can see it cooked into, like brownies and all kinds of, things that include butter and things like that because the THC is very lipophilic. It likes to partition to oils and things like that, right? That's why you see so many like baked goods and see it cooked into pizzas and all kinds of things, right? So what does that mean for its volume distribution? Well, because it's so lipophilic, it actually has a really high volume distribution. It likes to hang out into the tissues. And so a question you might hear from patients, and it's come up many a time, and they'll say like, oh, I'm trying to interview for a job, and I have a urine drug screen coming up. Am I going to be positive for THC? Okay, that's a really tricky question to answer because there's a lot of variables that go into it. And so what's interesting with THC, some drugs, if you do cocaine, 2 or 3 days afterwards, you test negative because it doesn't stick around in the system for very long. But something like THC that's very lipophilic, it likes to build up into the tissues because it distributes out into the fat tissue and all of that. So if you have a patient who has, say, a larger body habitus, they have some extra adipose tissue, they are smoking quite heavily for a long period of time, chronically, no pun intended, you're going to find they build up a lot of tissue stores of that THC, which is why some people can stay positive for 6 weeks, maybe up to 3 months on a urine drug screen for THC, versus someone who has, say, they are relatively thin, they may only smoke once or twice, and now they're going to get tested. They're much less likely to be positive for very long because they haven't had a lot of time for all that to build up into the tissues, right? All goes to how lipophilic the THC actually is. So just an example that comes up that patients might ask you about, right? Okay, so up next we have our metabolism, how we actually metabolize drugs. So when I say metabolism, basically what I'm talking about is getting a substance ready for elimination or getting it ready to be sent out of the body, right? And typically what we're going to find, a lot of the processes that we use to metabolize drugs is trying to make them more water soluble, right? Trying to make them more polar so they are more likely to be filtered by the kidneys and then eliminated in the urine. By far and away, the most common way to eliminate drugs from the body is through the kidneys. It happens through to the liver and through the GI tract to some degree, but for the most part, depending on the drug, the kidneys are where we're going to eliminate a lot of stuff, okay? But we got to get drugs ready for that. So frequently, they're not in a state where they can be they can be filtered by the glomerulus, so we got to get them ready for that. And that's where a lot of our metabolism occurs, which mostly occurs in the liver, to get things ready for that. So a lot of these are going to be deactivating reactions or detoxifying, trying to get them into more pharmacologically inert products. Actually, they have no more actual pharmacologic effect. That's not always the case. We'll look at some examples of that in just a moment. Keep in mind though that some drugs, when we give them by themselves, they're actually inert. They actually have no pharmacologic activity. And we recall there's a term called prodrug, where actually by giving a drug in this state, it's inactive on its own, but it has to be metabolized into the active form. So a good example of that would be things like your ACE inhibitors, which are antihypertensives, like the drug enalapril gets processed in the liver through that first pass process we mentioned until enalapril. This is the active form that actually lowers your blood pressure. Or like codeine I mentioned before, codeine actually gets turned into morphine, right? That's through metabolism that occurs in the liver there. Or the drug Vyvanse, which is lisdexamfetamine. This is a drug we use for ADHD, gets converted over into dextroamphetamine, the active drug itself. And so these are examples of drugs start out inactive, but then we make them active with the liver metabolism. Most of the time, though, we're going to find that we're trying to use the liver to make things go from active to inactive to get them ready to be eliminated. So, as I mentioned, there's other places that metabolism can occur. It can happen in the skin, the GI tract, lots of places, but primarily we're going to be talking about the liver here because that's where most of the enzymes that we're concerned with are going to come up. This is where we're going to see most of the drug interactions that come up here that are really important. And so we're going to go in much more detail about that. But again, main goal is to get them into a more water-soluble state so that way they can be eliminated through the renal system. We're going to talk about two main phases of metabolism. There's phase 1 and then phase 2 reactions. We'll talk about what these are doing here in a second. Now keep in mind, not everything has to go through phase 1. Some things only go through phase 2. Not everything that goes through phase 1 has to go to phase 2, right? It's kind of an either or an and sort of situation. It can be one, the other, or both of them. Depends on the drug and depends on what it needs to get ready for elimination. But phase 1 reactions here, we're going to see there's basically what they're doing is trying to uncover some functional groups, right? They're trying to change it and modify the drug such that it itself is either more polar or it's going to be prepared to undergo to a phase 2 reaction. I'll show you some examples of a drug that can actually go through multiple pathways in just a moment here. But some of the major classes of reactions here are going to include things like oxidation reactions, hydrolysis, reductions. All of these are included in your kind of normal phase 1 reactions. So there's a lot of different classes of enzymes that fall into phase 1 reactions. By far and away, the one that I'm going to be harping on the most, and again, if you had to remember anything off of this list, it's going to be cytochrome P450. If you ever heard of a CYP drug interaction, this is what we're talking about here. And this is really, really important. It's going to come up, okay? These other ones are also important, but in terms of drug interactions and things like that, they don't come up quite as frequently. So we'll get more into that in just a moment. But phase 2 reactions, instead of modifying the substance itself, what it's doing is adding something onto it, some sort of group onto that molecule that again increases water solubility. So for instance, if I conjugate something onto it like a glutathione or something, or if I can glucuronidate it or sulfate, add sulfate group onto it, those are things that increase water solubility, that increase its ability to eliminate it from the kidneys. So, and again, don't get too confused by this one. I'll just give you an example of how metabolism can occur. Imagine a drug is entering into the system here. It can undergo phase 1 reaction through, say, for instance, like a CYP enzyme, and then you have these phase 1 metabolites. It can either go through a phase 2 process here, or it can just be excreted in and of itself, right? Or some drugs may go straight to phase 2 and then be excreted. So again, I think I have another picture here. This is a good example. So here's the drug acetaminophen, or APAP, if you ever hear that. It's the abbreviation for that. So acetaminophen itself can actually go through a number of different pathways, and this is not unique to acetaminophen. Many drugs can do this. You can see that actually a lot of times it's going through some of these phase 2 reactions, right? It can undergo glucuronidation, or it can undergo through sulfation. This is the predominant way that this occurs. A small amount of it will actually go through a phase 1 reaction and actually go through the cytochrome P450 enzyme, right? So acetaminophen, small amount of it actually gets turned into this NAPK, and this then will then have a glutathione conjugation here, and then this is a phase 2 reaction and then be eliminated through the kidneys. So the reason why I care about this, because I'm a toxicologist, is because if you have someone who overdoses on acetaminophen, you can actually overwhelm these processes, right? Because the liver's not, it can't do everything, right? So if you overwhelm it, then you can find that these processes get depleted here. You run out of glucuronide to add, or you run out of sulfate, and all of a sudden now you have a lot of it going through this process here. And then if you run out of glutathione, now you're left over with this NAPK, a lot of this left around, and this is what actually kills your liver when you have a Tylenol overdose, right? But anyway, so again, I'm not going to quiz you specifically on the test. I'm going to say, well, what percentage of acetaminophen goes through glucuronide conjugation? But I want you to take from this is that drugs can go through multiple pathways, sometimes phase 1, sometimes phase 2, sometimes both. It just depends on the situation, right? And know that phase 2 reactions are typically adding something onto the molecule, whereas phase 1 reactions are typically just modifying it, usually to make it more water soluble. And again, here are just some different examples of different enzyme systems you're going to find out there. I'm not going to quiz you on which ones fall into which category. I would like you to know that cytochrome P450 is a phase 1 reaction. We'll talk about that because again, it's an oxidation pathways, so it's good to know. And then just anytime we're adding something onto a molecule, if I'm adding on a glucuronide group or glutathione, that's adding something onto it. It's a phase 2 reaction. So we mentioned the first pass effect last time as well, I believe. And so we talked about how when drugs get absorbed through the intestine, they typically most often get delivered to the liver via that portal system there. And some degree of it may be metabolized by the liver, right? In some cases with, say, you're doing with a prodrug, that's good because we want the drug to actually activate in the liver there. Some drugs can't actually be absorbed orally because so much of it goes through the first pass effect that you get very minimal amount of drug actually making it to the systemic circulation. So that's why some drugs cannot be given orally in some situations there. But you're going to find that the amount of drug that goes through first pass, what percentage of it actually gets metabolized there, is really drug dependent and varies greatly depending on the medication, as I mentioned. And what's actually interesting is you can bypass that by giving drugs via different routes. So for instance, like ethanol, you can actually get absorption via different routes. So I like to use ethanol because again, it's something most people have had at least some experience with. But ethanol itself is primarily metabolized in the liver. And so you can find that if you drink, say, like one glass of wine or something, right? Some amount of it, of the ethanol, gets metabolized by the liver before it ever reaches the central circulation, right? So what would happen if you bypass that, right? So if, say, for instance, I were to say bypass the liver, what if I were to give this via an alternate route? What could occur? And so there's been cases of people have died because they try to give ethanol via alternate routes and they bypass the first pass effect such that they get way more ethanol for one drink than they would if they had taken it orally, right? Been cases of patients who have tried to have rectal administration of ethanol, vaginal administration, and when you do that, those thin membranes can absorb the ethanol pretty easily, but they bypass the liver, right? By doing that, I mean they get a lot more bang for their buck, so to speak, and they get very severe CNS depression, respiratory depression, find them passed out, and they die potentially, right? So again, you can find that by giving drugs via different routes, you can actually bypass the first pass effect, get a lot more drug than you may bargain for, depending on the case there. Sometimes we do that on purpose because we get better bioavailability, but it all just depends on the drug. Do not do that, though. I would not recommend. Only if you're going to use ethanol, use it sparingly, and I'd say via the oral route is probably the most safe one. But anyway, so getting into the cytochrome P450 system, I talk about this one a lot because it is responsible for the majority of drug metabolism. Majority of drugs undergo some degree of CYP450 metabolism, and then we find a ton of drug interactions come about from interactions with the CYP450 system. So this is why I talk about it and harp on it so much. By the end of my class, you will know about many different CYP450s. You'll know about 3A4 and 2C9, all kinds of different ones. But what do I mean when I say that? Basically, CYP450 is sort of the overarching umbrella of these class of enzymes, right? So there's over 1,000 have been identified. There's a lot of them that are out there. The ones that we care about is maybe like 50. Maybe they're functionally active in humans there. And so we can actually break them down depending on their actual amino acid sequence, okay? So we're going to find that there's a lot of different varieties of them, and I'll show you some examples of this in just a moment. So let's say, for instance, I mentioned this enzyme last time. We have CYP2D6. This is the one that's responsible for metabolizing codeine over into morphine. And so here we have the enzyme name, the full name. CYP just refers to the fact that it's a cytochrome P450 enzyme. And then we get into the family, so it's a 2 family, has a subfamily of D, and then this final individual enzyme of 6, right? So you could have 2D6, there could be a 2B, B as in boy 6. You could have 2D5, or there's a lot of different varieties that are out there. And again, there'll be a handful of them that we're going to get pretty familiar with because they come up so frequently in metabolizing drugs and causing drug interactions potentially. Here's some examples of some of the common ones you're going to see here. And you can see some of the substrates that will be metabolized by those particular enzymes, right? Now, I usually have my students memorize this whole list here for the test. I'm just kidding. Don't have to do that. But the main thing you can see, though, is that there's a wide variety of things that can be metabolized by these different enzymes here. Now, if you had to take away a few that are more important than the others, say, for instance, they metabolize a lot of different drugs, you can already see, based on how big the list is, like 3A4, boy, that's a lot of drugs on there. That's probably pretty important. 2D6, that's a lot of drugs too. That's probably pretty important, right? And we'll get to a handful of other ones as well that we'll see that we'll know about as we talk about the individual drugs. Now, and another important thing to look at here is also this idea of inducing or inhibiting agents, right? So when I say an inducer, that means that when you're exposing the body or the liver to this substance, it actually causes an upregulation of those enzymes so that there's more of it available. So more enzyme available means it's more readily available to metabolize one of these substrates. So for instance, you could see a situation where if I were to give, say, a patient charcoal broiled food, say for instance you're socially distancing at a barbecue on July 4th, and you eat a whole bunch of charcoal broiled hot dogs or hamburgers, whatever, or veggie burgers, if that is your inclination, and they're smoking at the same time, you can see this induces 1A2, and that would actually lead to more sort of an enhanced metabolism, more quick metabolism of some of these drugs here. So for instance, like caffeine. So maybe caffeine doesn't work as well because it's getting metabolized so quickly. Levels of caffeine would actually go down because you've induced that enzyme, right? On the other hand, though, let's say I have an inhibitor on board. Let's say, for instance, we're looking at the inhibitors of 3A4. I mentioned, see if I can find a grapefruit juice, right? There are a group of chemicals I mentioned in grapefruit juice that inhibits CYP3A4. So by inhibiting that enzyme, now the enzymes are less able to metabolize drug. Well, what would happen to levels of those substrates, those drugs that get metabolized by CYP3A4? Well, they're going to go up in this case. Right? The inducer drops down the levels of the drug. The inhibitor is going to increase the levels of the drug. And why is that a problem? Well, that could lead to some significant drug interactions, right? I mentioned, for instance, with the drug, let's see if I can find it here. My statin drugs. So like lovastatin or simvastatin, those are the statin drugs that we use to lower cholesterol. In that case there, you would end up having increased levels of the drug because you're inhibiting those enzymes because you drink your grapefruit juice. And that could lead to that liver toxicity, could lead to that rhabdomyolysis, all those things, right? So these are really important when we get into them because you could potentially kill someone if you don't take into account the drug interactions that may happen with some of your patients and the drugs they're taking, right? Or you have to think about things like, hey, do I have to ask about if the patient drinks grapefruit juice or not? That could be a really important question and something that may not normally come up in your normal interviews with patients, right? So just to give you an example of sort of the breakdown of how prevalent what percentage of drugs are responsible for being metabolized by these various enzymes here, you can see 3A4 is like 50% of them. So this is an extremely important one. And in fact, by the time you leave my pharm class, if you don't know anything about CYP3A4, then I have failed you as a professor. But you see here, this is really important. You see CYP2D6 is really important, and then some other various ones here. But we'll probably get into those most commonly. There's a few others that are quite notable as well. And these are mainly your phase 1 sort of reactions here. You can see the oxidation is taking the lion's share of the pie graph here. And then looking at some other ones, so looking at your phase 2 reactions, you can see things like glucuronide transferases and glutathione. This is less important to understand, but just know it's pretty even split between all those different phase 2 reactions there. So not one is really more predominant than the other. But in terms of phase 1 reactions, CYP3A4 is super important. Or just CYP enzymes itself are very important, but CYP3A4 especially, since it's like 50% of drugs out there being metabolized by that enzyme. So you can find some other maybe non-liver areas where drugs get metabolized. So for instance, we can see that the gastric acids If drugs are not stable in acidic solutions, that can do it. Digestive enzymes. So this is why, for instance, we can't give proteins orally because they don't get absorbed because the digestive enzymes will just tear them up. So, for instance, insulin. You can't give insulin orally because the proteins, it's just a bunch of amino acids, they get torn up in the GI tract, right? Not only that, but even in some cases we may find that like things like gut flora are really important for processing things to absorb them. So for instance, gut flora is really important for helping us to absorb vitamin K appropriately. And if you don't know, vitamin K is really important for helping the liver to produce clotting factors. So if you have a deficiency of vitamin K, you can see bleeding potentially as a result of that. So little things to think about. We can see metabolism can be affected by things like liver disease. So if you have patients who have, say, long-standing hepatic illness, maybe they have alcoholic hepatitis, maybe they have hepatitis due to viruses, things like that. These are things that can slow down metabolism and can lead to those increased levels of drugs, such that patients are more prone to toxicity potentially, right? We'll see renal disease in some cases can affect metabolism, mainly because it's affecting how much fluid is actually being sent to the liver. So, for instance, if you have a lot of congestion on the venous side of things, and you don't have a lot of flow, say you have congestive heart failure, say you have renal insufficiency, you're holding onto a ton of fluid. If blood is not being delivered to the liver that's carrying that drug, then it's not going to be presented to be metabolized. So if you see a lot of hepatic congestion, that can also slow down metabolism quite significantly as well. So we see that a lot. Say, for instance, someone who is getting the drug lidocaine. Lidocaine's a local anesthetic used pretty commonly, but can also be used IV as an antiarrhythmic that can have slowed metabolism if given to someone with congestive heart failure and a lot of that hepatic sort of congestion. Other things as well that can affect this, so for instance, like with the endocrine system, hypo or hyperthyroidism can affect metabolism. Obviously, if you're in a hypothyroid state, kind of slows everything down, so that can slow down metabolism, versus hyperthyroidism can see the opposite effect, kind of speed things up from a metabolism standpoint. The genetic factors play a role. We saw that some patients, last week we talked about some patients being slow metabolizers, a CYP2D6, and some people being ultra rapid metabolizers, right? And that can affect how well things like morphine or codeine works in a patient, because how much they can convert over into morphine, right? We mentioned having diet and environmental factors play a role in this, so having inducers or inhibitors, for instance, can affect this. Age and gender potentially. Gender not so much, but certainly age. Older patients have a harder time metabolizing things. Really young patients may not even express certain enzymes until they develop, but we'll talk about that later as we get into pediatrics and the elderly. And then anything decreasing blood flow to the liver is going to slow down metabolism. Okay, a lot of different factors, and we'll get into the majority of those in Pharm 1 and Pharm 2 when we actually get into the specific drug. So I know I'm leaving all these cliffhangers for the next semesters, but I got to keep you interested to keep you around at least that long to enjoy the fall semester when we talk about drugs specifically. Anyway, so I'm at the end of my time. As I mentioned, I'm going to go ahead and I'll review that test once the stats are available, and I'll let you know if there's any high misses or anything. If you have any questions, please go and put them in the chat. I'm going to check the sticky board here. Let's see. So someone had the question. They were saying, is the difference between tachyphylaxis and tolerance the fact that tolerance requires more than one dose of a drug to lead to less of a response, whereas tachyphylaxis can occur as soon as one dose? That's a good question. So basically, these are processes that can happen over either a short period of time or a longer period of time, depending on the drug, depending on the patient, depending on a lot of things. So unfortunately, it still goes back to it depends, right? So for instance, with like tachyphylaxis and nitroglycerin, that's a 12-hour process, right? You do 12 hours on, 12 hours off, because you can deplete all those cofactors and things and have that tachyphylaxis effect after 12, 24 hours, right? With tolerance, basically, you just have to give more of the drug, right? So you can give a bigger dose in order to overcome that and get the pharmacologic effect that you're actually looking for. So that's the other thing to think about, is I can give a bigger dose. With tachyphylaxis, I can't overcome that effect once it's occurred. I can just withdraw the drug, allow the body kind of reset itself, resensitize, and then it's good to go at that point. So hopefully that answered your question there. So any other questions that I can answer for you at this time? Not seeing anything in the chat or on the sticky board. Oh, I have another question here. Let's see. Put this back over. It says VD is theoretical because the amount of body amount in the body is actually the dose given, and we are assuming 100% bioavailability. So when I say volume distribution is theoretical, it's because when you are giving a drug and you calculate the volume distribution for that patient to be like, 100 liters. Like, well, we know there's not 100 liters of fluid on that patient. Like I mentioned, if they were, they'd be a big bag of water, basically. So that really wouldn't make sense. So that's why those values are theoretical, because it's basically just because you'll find that tissues can concentrate that drug. Drug can concentrate out in the tissues there, and that's why that value, that C0, can be so low for drugs with really big volumes of distribution there. Normally, when I'm giving you an example, we're assuming 100% bioavailability. So, for instance, if I give a drug IV, 100% bioavailable because I put it right into the system, right? But if I were to say give you a test question, I was to ask something about a concept here, I would either tell you, yeah, assume 100% bioavailability, or unless I say otherwise, you can just assume it's 100% for sure. Dave was asking if we're going to finish this PowerPoint later. Yes, I'll finish it next week, and then we'll do the fourth PowerPoint as well during that class session. So it'll get us back on track. See, any other questions? If not, you certainly have my email address. You have Canvas. You can message me through. Remember, I don't check the sticky board except for class time. So if you post something up here, I will not see it till next Friday. So just FYI about that. Yeah, but otherwise, you guys all have a great weekend, and I will see you. I'm actually not sure. I don't know if we meet next Friday or not. Next Friday is July 3rd. Let me see. Yeah, so we are not meeting next Friday, but we will definitely meet on the 10th, so I will see you there. And yeah, so have a great time. Hopefully you stay safe on your 4th of July weekend when you have that, and so stay socially distant. The cases are rising, so stay safe, wear your masks, and all that good stuff. And I will see you all later. Thanks a lot.